So I'm Karen Walls and I'm the clinical lead occupational therapist in the Northern Trust for a team of occupational therapists specialising in dementia. Okay, so all I'm here to do today is to give you a short overview of the Northern Trust's occupational therapy project on the use of GPS systems for people with a diagnosis of dementia. So just for anybody who doesn't know, and I'm sure with the audience today everybody's very aware that a GPS system locates a person by satellite and then transmits details of their location via the mobile phone network, and that can either be to your computer or to your phone. So our clients wear a device which will alert the carer's telephone or computer or smartphone if they go outside a preset boundary, and carers can also check the location of their loved one by logging onto the system. So why did we decide to go with GPS? Well, from our experience as occupational therapists being out and about, we realised that obviously sometimes with people with dementia we're getting lost. We know that that comes with risks of mortality, injury, dehydration, just among a few. But I suppose what we did notice on a daily basis was that our clients who were living with a diagnosis of dementia were experiencing a loss of confidence. And this was coming very often through the loss of a life role and the loss of a hobby. This was very often something that was very important to them, and it was usually walking. We realised that that was impacting, as I know Sue talked about in her presentation at the beginning, that this contributed to an increase in caregiver burden. It most certainly had an impact on the relationships within the home and an increase in conflict within that relationship. And what we were finding, anecdotally without doing any research, was that this is definitely contributing to premature admission to care homes. Right, so we thought, what can we do? And we thought, right, GPS. So why? We thought it might help maintain people at home for longer. It might help them maintain their existing hobbies. We wanted to promote purposeful activity. That's the core of occupational therapy's business, I suppose, in promoting independence and promoting the person with dementia's quality of life. But we also thought it'll also very much contribute to reducing caregiver stress, reducing their anxiety, and also therefore contributing to improved quality of life for our carers as well. We could see that there was some intrusion into the person with dementia's right to privacy. So we said how can we enable these people with a diagnosis of dementia to continue to live and to enable them to go out on their own for walks as they have always enjoyed doing. So we thought we all have a right to choose to go out on our own where we choose and when we choose, and that this shouldn't end with a diagnosis of dementia. But if we introduce this piece of technology, they continue with this right, but all in the knowledge that if they do get lost, someone will find them. Okay, so we devised some criteria that we thought were important in setting out, I suppose. I'm not saying this has to be criteria for everybody that's going to look at GPS within their workplace, but we thought as a starting point, we would like our service users to have capacity to consent. So we wanted our service users to say, yes, I understand what you're talking about, and I think that's a good idea for me to enable me to continue with my hobby. So we completed a road traffic assessment as well, because again, we felt as occupational therapists working for the Trust that we didn't really want to be promoting a hobby that wasn't safe. So we didn't really want to be promoting and encouraging people to go out for walks on their own if they weren't safe to do so. So if they were moderate to late stages dementia and we thought that their attention was poor, their concentration was poor, their awareness of safety was impacted, that their gait was so poor that they were going to be at risk of crossing the roads, we weren't going to contribute to that, I suppose, by prescribing GPS. And that was our decision within the occupational therapy team. And we also thought it was important that our service users, obviously they had to either remember to wear the GPS or have somebody to put it on, because it isn't going to work otherwise. And you also need a responder. So again, that's feeding into the telecare as well, and having that social contact. You need some form of social contact, somebody that will realise that you're either out too long or that you've got lost. And obviously to do that you need access to either a computer or a phone. and they needed to be able to wear it. That we did find that was a small barrier maybe at the beginning of the project, which is going back about 6 years now too, because not all our carers had access to either a computer or a smartphone, or they didn't know how to use it. Okay, so for our project, we excluded, as I discussed, those who were unsafe to go outdoors alone. For our project, we excluded those living in a nursing home because we really wanted to maintain people at home for longer, and that was the main aim of our project. And obviously we didn't want to cause any stress to the person or increase confusion. So if it was causing any anxiety or stress, it maybe wasn't the right piece of technology for that user. Okay, so as we talked about, we looked at their capacity to consent. We needed to look at their route and routine, because GPS works more effectively if people are going generally around the same route on a daily basis. That wasn't an obstacle for us at all. We found that most of our users, they either had 1 or 2 routes that they tended to go with their dog or wherever it was. That wasn't an issue. But if there was too many routes, then it's too difficult to set up your boundaries and your geofences to get the alerts if they go outside the route. So it just makes it a wee bit more complicated. Personal history and cultural issues. Again, maybe if people were alive at the time of the war, they maybe wouldn't be so keen on the idea of being tracked or tagged or wearing any of being followed, I suppose. We also needed to look at the differences in perception of risk, and that was between the carers, the person with dementia, and the professionals involved. So sometimes professionals can overemphasise risk, sometimes carers can overemphasise risk. So we wanted to make sure, is there really a problem here? Is there a risk? Is there a stressor, whether it be to the client or the person with dementia? Okay. So who's going to put the GPS on in the morning if it's somebody who's living alone and they're not going to remember? Who's going to respond immediately to the alert? The level of computer literacy. Who's going to charge the device? It's very small, it can easily be lost, and satellite signal can affect the accuracy depending on where you live. So they're all the factors that we considered in the product choice. We also were very clear that clients and carers would need clear information on the use of the GPS. They would need time to ensure the person with dementia understands how to use it and why they're carrying it. Advice on who to contact should there be any problems arise with their GPS. And to back this up, well, there was always an initial visit from the occupational therapist. Referrals never came in for GPS, they tended to come in for something else. So they had an initial assessment, then they would have a follow-up visit to discuss the GPS, and at this stage we would provide a leaflet for carers and the person with dementia to improve their understanding. And we felt it was important to leave something behind with them that they can have a look at it and discuss it with their extended family as to what they were buying into. So as we talked about, we had preferred consent of the person with dementia. We had a clause that if they couldn't give informed consent, then a shared decision-making approach could be considered and adapted. In fact, we've never had to use this. Everybody who we have had within the project has given their consent willingly. And we'd always be considering the past, current, presumed or known wishes of the person with dementia. So how exactly does it work then? There's safe zones or geofences set up, and that's based on all the lifestyle information that we get from the client and their family. And if the service user goes outside the boundary, an alert is raised, and this can either be via email alert, text or phone call, so it's whatever suits the carer. And if they don't return within the expected period of time, most people in Newark, it usually takes 45 minutes or an hour or 2 hours or whatever the length of time will be. But if that period goes well beyond that and the carer's getting really anxious, then they can check their whereabouts online. And you can do 2 things. You can actually go on, there's log-on details, they can go onto the computer, they can see exactly where they're at. But if people aren't overly computer proficient, there's also a telephone number that they can ring and they're given their exact whereabouts at that time. There's beacons available where satellite reception is poor, and we're finding that in things like apartment blocks or in just very remote areas. Best practice, we did advise our carers not to track the person's whereabouts in the computer. We felt that was just maybe a slight invasion of their privacy. We said, try your best only to track them if there's a reason for you to be concerned. So if you're worried and you think they're away too long, or there's some fear within you, then certainly log on and have a check. But we weren't encouraging people to track and follow them every step of their way. And we thought this was important to protect people's privacy and autonomy. So the system that we use within the Northern Trust is a system called Buddy, and it's working very well for us. It's a 24-hour call management system, therefore reliability is high. From the wee bit of research that we did within the team, we seem to see that it was tried and tested in Britain. It has an annual reminder with us to renew, and that reduced admin time for us as OTs. And it had some added extras such as a falls alert, and we felt this was very beneficial given the client group. So I'm just going to finish with a couple of case studies. So we have a Mr. X who lives with his wife, always enjoy going for daily walks, maybe 3 to 4 miles. 3-year history of Alzheimer's disease, and it continued with these walks. This was a very important role and hobby to him. He really enjoyed it. Give him a great sense of well-being, but his wife became increasingly concerned due to the deterioration in his cognition. He was very keen to continue walking. There was conflict at home and increased anxiety. So when we introduced and completed the OT assessment, we deemed him to be safe on the road. As explained, maintaining the role of the hobby was an occupation that was very important to him. He wanted to continue this autonomously. Both him and his wife explained that it definitely maintained his mood, and promoting that level of independence had a great impact on his mental health. And so we thought GPS was appropriate, and he consented to it. The carer is able to access the computer and is available to remind the client to wear the GPS, and is available to charge it. This particular gentleman has been using it for over 1 year, and the carer has given statements like, "This is the best device, it's made such a difference to our lives." It gives great peace of mind, the carers are all very reassured, and it just allows him to do normal things, such as going for a walk. Most of the examples are the same. In this case, to be honest, they're all people who just want to do normal things, like go for walks, and they have a carer who is anxious about them, and it's causing problems within the home. So this 73-year-old lady lives with her husband. She goes for daily walks, the same general route. Reports from her husband of her walks were getting longer, and he was worried and anxious about this. She was very keen to go walking alone. She didn't want him to walk with her, and he didn't really want to walk with her either, to be honest. This was something that they did separately and enjoyed. And as carers, I suppose it's a very intense relationship in the house together, 24/7 often. So this time out is the only respite that the carer gets and the client gets, and that's reality. So the full OT assessment was completed again, and road traffic, walking was very important, time out through the hobby. The husband was computer literate, and again it's been used successfully for over 1 year, and they felt that it really benefited them and was very worthwhile. So we did a service evaluation, and all clients and carers with no exceptions said that they found the GPS very beneficial. They found it very easily used. It decreased their anxiety and enabled with the person with dementia maintain an existing hobby for a minimum of 1 year. The assessment and the OT support assisted the decision making about the suitability and the usage, and improved efficiency of the device, what we found within our department. And we would suggest that further research, it probably has been completed somewhere, would be required to quantify the savings from using GPS in terms of residential care, hospital admissions, or informal care breakdown. It definitely maintained and promoted independence with existing hobbies and all the benefits that came from that. And within our department, we're going to continue to prescribe GPS within an ethical framework. And the College of Occupational Therapists would say it is suitable for use in dementia care, provided that it is applied in a way that respects the personhood and maintains functional capacity. I think that's important. Yes. And then, yeah. So we won a project this year, and it was the Dementia Design Project of the Year with the Dementia Centre Northern Ireland. So we were pleased with that. That's it. Thank you.